Most of you do try to drag it into your med-surg class on Wednesday mornings, which is good. Okay. So, hi. This is med-surg Nursing 2020. March 18th, 2015. Coming up not too far after next week on a little spring break, but not yet. So before you do that, we have test number 3 next Wednesday. Yes, you're thinking about your PEDS test today. However, you're taking 2 courses. They're not on the same day, but next week is your med-surg 3 test, which will cover competency 7, diabetes mellitus. That lovely chapter. But do you need to know diabetes mellitus to be a registered nurse? Absolutely. In great detail, right? The entire nursing process. We covered that. We also talked last week about competency 8, which is the rest of the nursing management of patients with endocrine disorders, right? Which we focused on the pituitary gland, the thyroid gland, and the adrenal glands. Okay, today, what are we doing today?
Autoimmune disorder.
Good. Competency 9, which is on connective tissue diseases. We have a nice chapter in IGGI for competency 9. Chapter 20, right towards the front of the book, chapter 20. Care of patients with arthritis and other connective tissue diseases. This week in SimLab, which one group does today at noon and the other group does tomorrow at 11:30, you're going to take care of Lloyd Bennett. We may have met before, our Sim patient, and he's going to be status post hip replacement, getting a blood transfusion. Okay? I'm standing. There we go. So that will apply to this competency. I'm not sure the group on Monday understood that this Sim patient actually went with the class because they hadn't had the class yet. But this is all to tie together application of the nursing process in the care of a patient after a total hip, right? So in the chapter, in the class, we're going to talk about joint replacements in addition to arthritis. What are the 2 types of arthritis? Actually, there's over 100 types of arthritis-related diseases that rheumatoologists take care of. But what are the 2 major types of arthritis? Osteoarthritis, which you've talked about before, and rheumatoid arthritis, which is an autoimmune connective tissue disease, right? Okay. Before that, I wanted to introduce, if you didn't know, Miss Cooney, Teresa Cooney, who is actually a PEDS adjunct. Oh my God, I'm so glad you brought these. I'm just kidding. She's a PEDS adjunct, and she also is a graduate student, okay, getting her master's in nursing education. With Dr. Dover as her mentor. Okay, so she's going to join us and join hopefully our groups. In the spirit of the test next week, this handout you got, I think I even kind of mentioned it last week, but I didn't have the question. These are 2 questions related to competency 8. I like to do these questions as a class discussion before we do competency 8, because what I want you to understand when you read these is that you don't need to know what the content is to answer these 2 questions. These 2 questions you can answer by using what? Your test-taking skills.
Where I'm copying.
This is from competency 8, okay? So this is kind of review of thyroid. We did diabetes, last week we did thyroid, remember? Okay, so I did tell you you need to know hypo and hyperthyroidism for the test next week. You can't fake that. If you don't understand hypo and hyperthyroidism, it's not going to work. You have to understand so you can apply that to the test. So there are a lot of questions about thyroid disease on the test next week, and a lot on diabetes and the stuff we'll do today in competency 9. All right, so let's look at the first question on here. Propylthiouracil is ordered for Miss Wise with a diagnosis of Graves' disease. Which observation would indicate to the nurse that the medication was having a therapeutic effect? Now, if you didn't know what Graves' disease was, and or you didn't have any idea what PTU is, you can still answer this question. What do you think the best answer would be, even if you didn't know? So there's 2 key things in the STEM. What are they? What is it really asking you about? A therapeutic effect of a medication. That's what it's asking you about. Now, it's nice to know what Graves' disease is, and it's also good to know the medication. But if you didn't know the medication, you could still answer this question. Why? Because the question's asking you about a therapeutic effect of medication, isn't it? So look at the choices. A, weight loss of 1/4 pound a week. B, apical pulse of 90, less urine output. C, ability to sleep 8 hours a night without awakening. D, inability to complete a paint-by-number picture. C. Why? Because that's a therapeutic effect. What is a therapeutic effect supposed to do? Make you better. Mitigate the symptoms. Control the disorder. So C is obviously the answer because 3 of these are problems and 1 is not a problem. So now we know, so what is Graves' disease?
It's
Hyperthyroidism. It's the most common, it's an autoimmune disease, most common type or cause of hyperthyroidism. There are others. Okay. And when somebody's hyperthyroid, what does that mean physiologically?
weight loss.
It means they have a high what? Metabolism. Their basal metabolic rate is higher than normal. So they're going to do things like A, lose weight, right? That's hyperthyroidism. They're going to do things like tachycardia. That's normal sinus rhythm probably. We don't know anymore. But it says 90, so it's a little fast, but that might be the disorder itself. If it affects cardiac output, they could have a little less urine. And D, what does this mean? Inability to complete a paint-by-number picture. What are they telling you the patient's doing? They're telling you their hands are shaking. They're telling you their hands are shaking. Tremors. Okay. So those are 3 symptoms of hyperthyroidism. What is C relating to? What's a symptom of hyperthyroidism? Insomnia, talking about sleep. So we know insomnia is the disease. The fix is to take your PTU, which now you know is what? Even if you didn't before, you should. It's an anti-thyroid drug, right? It's an anti-thyroid drug which decreases secretion of T3 and T4 from the thyroid gland. So if they did have insomnia, now their medication is lowering their thyroid hormone levels to hopefully euthyroid or normal, and they're sleeping through the night. But that's test taking, isn't it? Oh my God, I don't know what PTU is. Read the question. If the question's asking you about a therapeutic effect or therapeutic benefit of the medication they're taking. Doesn't even ask you to, doesn't say what are the side effects of PTU. But let me ask you that. If it's propylthiouracil or Capizole or Lugol solution will decrease thyroid hormone secretion, right? So if you're taking an anti-thyroid drug and you take too much, what are the side effects going to look like? Lethargy, weight gain. She's right. Come on. Everybody else, join in. What happens to your pulse?
Bradycardic.
What happens to your mental status? Lethargic. What happens to your GI tract? Slow. Okay, so what are we talking about here? The side effects of too much anti-thyroid med for hyperthyroidism makes you hypothyroid, right? If you take too much anti-thyroid, it makes your thyroid run too slow. So conversely, what's the medication we give for hypothyroidism? Synthroid, which is a brand of levothyroxine. Exactly. So what would the side effect profile of Synthroid be? If somebody is hypothyroid and they're slow, cold, and dry, and you give them too much Synthroid, what would they start complaining of? Symptoms of hyperthyroidism. What would happen to their pulse? Tachycardia. What would happen to their GI system? Diarrhea. What would happen to their mental status? Anxious. What would happen to their sleep? Insomnia. Okay, so that's how the endocrine system works. If you take too much medication for being hypo, the symptoms will look like hyper, and vice versa. Okay, good. Last question. Now Miss Wise has a subtotal thyroidectomy. Let's say the meds didn't work, so now we have to take out what? Part of her thyroid. Subtotal thyroidectomy. The nurse can detect early hemorrhage by noting A, BP of 90 over 50, apical pulse 150, clammy skin. B, muscle twitching and tremors. C, hoarseness and weakness of the voice. D, complaints of difficulty swallowing and sensation that the dressing is tight. Okay. So what are the key words in this step? There's actually two. One is hemorrhage, and the second is early. Thank you. So we can get rid of two choices right away because they don't relate to hemorrhage. Now, when you take out the thyroid, you can nick the laryngeal vein, nerve. And so hoarseness and weakness of the voice could be from the surgery, but it's not related to hemorrhage. Same thing with B, muscle twitching and tremors. What are they talking about there? That's a possible side effect of thyroidectomy. Related to what? Hypo what? Good. Hypocalcemia, right? Low blood calcium levels, which can lead to hypocalcemic, what's the word? Nope. Hypocalcemic, when you have the muscle twitching, the Schwastek sign, the Trousseau sign, whatever, what's the other thing that thyroid controls besides your metabolic rate? Your blood what? Calcium level. Okay, that's all right. Okay, let's go there. Muscle twitching and tremors. So if you have really low blood calcium, you can get the muscle twitching, the Schwastek. So if you learn about Schwastek and Trousseau, you got to connect it to something. It's connected to hypocalcemia. That's what causes it, right? Okay. So there is a word that starts with a T, and we use it when somebody has very low calcium levels and they're twitching. Tetany. Thank you. Good. Hypocalcemic tetany. So that would be B. But that's not hemorrhage either, right? So now you got A and B. Okay, so who thinks the best answer is A? Okay, got to vote. Doesn't matter whether you're right or wrong. Okay, all right, good. Who thinks the answer is D? Okay, it's about half and half. Okay, very good. All right. BP of 90/50, apical pulse of 150. Now here's the other word. Remember what was the other key word in the stem? Early. By the time you're shocky, you're down a couple quarts. You're pretty hypovolemic by that point, aren't you? So by the time you have those kinds of vital signs changes, and your blood, your diastolic is 50, and your systolic is 90, that's not early hemorrhage. That's not early, that's late. Or later, your hypovolemic shock, right? All right. And why is the apical pulse 150? Because your heart rate is still trying to compensate for the hypovolemia. What's cardiac output? Cardiac output is two things. Stroke volume times heart rate. So if your stroke volume is low, your heart rate's going to try to compensate. All right, but that's not early hemorrhage. The answer is B. The answer is complaints of difficulty swallowing and a sensation that the dressing is tight. First part of that, where's your thyroid? Here, what's behind it? Your esophagus, okay? So if you're bleeding, we don't know whether you're bleeding in and that hemorrhage is against the esophagus, or we're bleeding out into the dressing. If it's bleeding out into the dressing, they might feel that the dressing is tight because the blood is coming out through the incision into the dressing. And what position do we put somebody in after a subtotal thyroidectomy? Semi-Fowler's, maybe even a little higher. So are they going to bleed straight out? Are you going to see a nice round blood thing right there? No, they're going to bleed down, gravity, and it's going to be at the bottom, and you may not actually see it. They might just have what? Complaints that the dressing is tight. So you can answer that question also by looking at the keywords in the stem and using your test taking skill. Okay? All right. Was that helpful?
Yes.
Cool. That was your competency 8 review. All right, competency 9. Open your study guide to page 123 and 124. I kind of Xeroxed weird, but that's okay. We still have 4 case studies. Oh no, Mrs. Heng's going to make a few case studies. Yes, she is. Okay, so on page 123, patient number 1, degenerative joint disease, received Tylenol for pain, etc., etc. Why don't you guys right here in the first row? You'll just do case study 1. Okay. All right. Rheumatoid arthritis.
Come
You guys right here.
Yeah, right.
That's turn around. 59-year-old woman with rheumatoid arthritis. Page bottom of page 123. Answer the questions. Somebody's going to present in about 20 minutes. Okay, you guys can do number 3.
Right.
X-ray number 3 on page 124. Okay.
Voice,
Alright.
client, with degenerative joint disease.
And then you guys will do
Tylenol.
number 4.
Receives it.
He has very little relief from the drug and is sometimes unable to sleep due to severe pain. Client states that she uses glucosamine at home.
Previous years and now she's had
What should you include in her comprehensive pain assessment?
people with RA, especially before they had biologic drugs, had a lot of joint replacements.
Well, let's see which joint disease she has.
Degenerative joint disease.
I know. What is that? Rheumatoid or is
You
that
can use your books, open your
osteoarthritis?
chapter 20, it's all in there. They have osteo, they have rheumatoid arthritis, they have lupus, which is what you guys have, and they have joint replacement.
Okay.
All in the same
Degenerative?
chapter.
That's osteoarthritis. Okay.
So this will familiarize you with chapter 20.
Mm-hmm.
We will get to the
Most common
Managing comedy. Okay. It starts on page 321 and it goes on and it talks about managing the pain.
321.
Page 321. It starts here at the bottom. Surgery may be performed. Analgesics, rest, positioning, thermal modalities, weight control, integrated therapies. They usually recommend Tylenol, which is what she's getting. They also do topical drug applications. Then they go into NSAIDs if acetaminophen doesn't work. Celebrex, they do that one. Cortisone shots. Then they go into other agents up here, muscle relaxers, hot and cold applications, weight control, exercise, joint positioning, rest. If, depending on where it is, use a cane, immobilizing the whole body, psychological rest, position joints in their functional position. So, like, don't, like, like your hand is normally, like, relaxed like this, so don't sit there like this. Legs may be elevated, wear supportive shoes, hot and cold therapy, like I said. Diet, weight loss, again, acupuncture, and all that other stuff. Okay.
What should you include in her comprehensive pain assessment?
I guess, I mean, that's generalized pain information. Where,
Intensity,
when,
quality.
yeah.
PQRS, is it?
Well, the pain scale. Where is it? What type of pain? What alleviates the pain?
Mm-hmm.
And what stresses the pain? No, it says she only takes the Tylenol for pain when she requests it. Maybe if she started doing like
Yeah.
more
Before the pain
before
starts.
the pain
Like around the
starts.
clock, right?
So when does she take the medication? Like how bad does her pain need to be before she takes her meds?
Let's take it around the block.
Hmm?
To take it around the block
Mm-hmm. Yeah.
to minimize.
Mm-hmm.
Okay. So number 2, what options does she have for pain control? A topical agent, such as lidocaine patches.
Topical agents.
An NSAID, which is, they recommend Celebrex, cortisone shots, muscle relaxers, such as Flexeril. Rest, hot and cold applications, position joints and correct positioning, elevate legs. That's it. I guess that would be if she has it in her legs. So then if you elevate them, then you don't get venous pooling, and which is increased pressure on it. Supportive shoes. Weight loss. Acupuncture. Okay. What intervention should you take based on her pain assessment? Oh, hold on. It says that she uses glucosamine at home. It decreases inflammation.
Oh, it increases inflammation.
Yeah. It's a dietary supplement. They're the most effective non-prescription supplements taken to decrease pain and improve functional ability. These natural products are found around bone cartilage for repair and maintenance. Glucosamine may decrease inflammation. The other one strengthens cartilage. They may be used topically or oral form. If no improvement is evident, 6 months of use, they should be discontinued. So we should ask how long.
Is she taking the glucosamine, right?
Monitor for bleeding. No, that's if she's taking the other one. Monitor glucose levels. Monitor for side effects such as rash, GI disturbances, especially diarrhea, drowsiness, headache. So these right here, I guess would go up here with pain assessment.
Yeah.
What intervention should you take based on her pain assessment? We can do hot and cold applications.
Maybe some distractions.
We could call the doctor for a different medication since this one's not working. Elevate legs. So I think up here we have the topical agent, the NSAIDs, the cortisone shots, and the muscle relaxers. Those can be her pain options, and all of these right here, we can use these for interventions. Positioning, elevate legs, supportive shoes, discuss weight loss, acupuncture, we don't do that, but we can
suggest.
Yeah. Yeah. Okay, I think we're done.
You got it.
I'm not here. I'm lost.
Where's Namada?
I don't know.
Not seen her. And I've not heard from her either.
Did you both get one of these?
Yeah.
Did you get one of these? Okay. Sounds good. How was clinical on Friday? Did I miss anything good?
No. Nothing much.
Oh yeah.
Just our usual self.
What's that? Come.
We were like, we got there early, and I don't know, maybe she was late. And instead of her, like calling us, oh, if we're ready, let's go in. She just came out, come, they are doing huddle.
She is bananas. I can't stand her. Although she was really nice. My sister-in-law had surgery. She had her tubes taken out, and that same day her 3-year-old came down pink eye and double ear infection. And she couldn't, she can't lift her kid. She can't, take care of her kid when, she just had surgery. So I had to go up to my sister-in-law's house for the weekend and take care of. But she was super nice on the phone when I called her. I was like, "Look, I have a family emergency. My niece is like super sick, and my sister-in-law can't take care of her." And she was really cool about it, actually. So I was surprised.
Yeah, I don't know, maybe. I don't know.
Yeah, we
Sometimes
thought-
it's like,
I thought she was very late.
yeah, she was late, and
How late was she?
I don't.
Because it's already 7 and
Yeah, we were still out there, and she didn't come out. Usually she would come out like 10 minutes to 7. She never came out until it was time for huddle.
Oh, good. She's
Yeah, and then she just came in. Hurry! Like, we are the ones that are late.
she's bananas. I can't stand her. Oh. Did you do meds with her?
yeah,
I don't like doing
usual.
meds with her.
it's taking you like taking too long.
Did she collect patient profiles? Did she give shit to people who didn't have them? Because I know some people haven't had patients.
Oh yeah, I think she gave them 1 week.
Yeah.
So are you ready?
Oh my god, for the peds exam? I'm not too worried about it. I heard that she's going easier on us this time, and I didn't do too bad on the second one. I really didn't, considering how everyone else did. So I'm not too worried about it. And you know what? At this point, I just say fuck it. I don't care. I'm passing, and I'm passing by like 10 points, so I'm happy. I have like an 85 average. Good. Whatever. I don't need an A in her class. I don't think she ever gives out A's in her class.
Right.
Did you get the computation right for the last exams?
Did I get which one right? Which one?
The computation, the last one.
For peds?
Yeah.
I got the number right, but I didn't have. I said hold the medication,
Yeah.
but she ended up giving it back to me, so I ended up getting my points back. Did you get your points back for it?
Yeah. Also, it's for that. Okay.
It was that one, and she gave points back for the pneumonia question because she actually had the wrong question.
Oh, the pneumonia that you can, like,
She
treat
wanted
it
us.
at home.
She wanted us to circle bacteria is the most common cause of pneumonia.
Okay.
Was it pneumonia?
It's alternative questions.
Yeah.
Questions.
And because the question was wrong, because apparently it was supposed to be bacterial pneumonia, but it just said pneumonia, so no one circled it. So apparently she gave that one back to us.
How are you guys doing? I think you guys had the shortest. Yeah. For every one of these case studies, make sure you can explain the pathophysiology of why they have you know, these symptoms?
Alright. If you need to know the patho, it should be over
Yeah, the pathophys is something you have to always
right
know
here.
about a condition before you can do the nursing part.
Cartilage changes from normal to yellow brownish. Joint space narrows. Bone spurs form.
Where do you read?
Fissures, calcifications, ulcerations develop.
But you need to understand why she needs to deal with it because of the RA.
Disintegrates and pieces of bone cartilage float from disease, causing decrepitude.
Now, but she may have
So
had-
essentially it just wears down your joints.
It doesn't say she's immediate post-op from the knee. Yes, they do. If they think it's really going to work and help her with her mobility. Yeah, they do them. I've seen them at night.
I didn't do the
really
stupid
are.
GU stuff either for
Maybe not always.
beads. You know, she posted that. I
They
was
do.
like,
Time to do
what
that.
the hell am I going to do that?
Please.
Crazy lady. She's insane.
I'm not doing it. I may not even stay for the lecture. I mean, it's useless, really.
Did the meds, okay. How long do you need? Maybe 5 minutes? Are you pretty much ready?
Yes.
I can't stand these
No,
case
it's
studies.
useless. We're taking a
I don't
class.
know.
It's an online class.
Yeah.
Good,
Yeah.
good. How are you guys doing? Are you ready to present?
Because if she teach, it
You're having
will,
a good
you know,
talk, but
help
nobody
us.
needs to
But she's
present.
not teaching.
5 minutes.
Do you want me to present?
Yeah, just, I'm so blank.
We'll start
really.
presentations in 5 minutes. That's what I said. That's the time I gave you. You're not quite done. Do the best you can with it. Get the answers for the class.
You know why? I had to do my exam on site this morning.
So the fourth exam is
Because
going to be,
The fourth exam is competencies 10 and 11.
so it's only
Do
2
it.
competencies.
I did not
Okay.
read.
Yeah, the cancer stuff. Competency 12 is on the final.
Okie dokie. The same day as the peds one.
Recording for
People are going to come in and
Right now, we don't have any other rooms or days.
I can't
I
hear,
think
so
Keats
I
has
like-
moved before, but I don't know if they are this time. It says it's the same day, it's the same day. You guys have this too, for your rheumatoid arthritis patients?
she's far away from her. She should be like next to
Picture, I use
me.
these.
Are you super excited about that? That our peds final and our med surg final are on the same day?
No.
I'm gonna come in here and I'm gonna be like literally like I get to see myself just like drained. My hair is gonna be like here.
Michelle,
I know.
Why do they have to do that? I don't know, but it's mean. It's really mean to do.
I know.
she bought the CD.
So it's on Wednesday?
In her house,
It is on
Yeah, it's Wednesday.
and I just bought the book.
Should
And I
it
don't
the 6th.
On the 6th, maybe we have the other exam.
The what? The Evo? No, it's 7 to 9.
It's
7
moved
to
over
9.
here.
I'd like to know when registration is because
I know,
I have to
me
plan my
too.
summer.
All right. Looks like this group is, they have a kind of the shortest, least questions one. And they look like they're sitting here ready to go. So
I'm not complaining.
1 or 2 minutes, wrap it up. The point, of course, of this is that you're going to learn from each other when you present. So you might want to take notes from the other case studies. There are 4 different situations.
Miss A.
Yeah.
Registration for 4th semester.
Dr. Dovert handles it all.
Okay.
You can't do anything without going to the time and date she says
Okay.
and doing it through her. And then she
Okay.
actually registers you.
Yeah, I know. But
You sign up for your sections.
Yeah. We
At that
usually
time.
have that.
And then she puts
Usually
you in.
it's in like June, right? When we.
Oh, yeah. Oh, yeah, yeah. Now, I'm not sure when she's going to do it. She hasn't said yet.
Okay.
Sometimes she does it before the end of the semester. Sometimes she waits until right after the end of the semester. I think she's gone now to right after the end of the semester.
Okay.
That way she doesn't put anybody in that she needs to take out.
Okay.
So after the grades are basically done, she does registration. And then you get registered
And I'm
for
gonna
what you're
email her about
eligible for, which for you guys should be Nursing 2031, which is psych, Nursing 2032, which is med-surg, and Nursing 2040, which is her Dr. Dover's management class. They're three credit courses, and you have to take them all together.
Yay! Last semester.
Right. 3. 9 credits.
I need one more to make it.
Yeah, I mean, you've had
I need
close to 9
speech.
credits.
I don't know.
You've had 8. You've had 7. More than, yeah.
Peds feels like a 15 credit class.
Right, it really is hard to, it's hard to justify some of that, because even the 3 credit courses, feel like they're just as much.
Yeah, I mean,
Even though the lectures are shorter and the clinical days are shorter.
I really feel like I did more work for OB last semester than I did med-surg, and definitely Peds this semester.
Yeah, I know. Yeah, I don't feel like 2032 is any less work than 2020. But 2032 is 3 credits, and 2020 is 5.
I just can't wait to be done and get pinned.
Yep. Oh, I get pinned today. I get a 20-year pin.
Congratulations.
Yeah.
Yay!
Yeah, Dean Anderson and I started in summer of '94, so it was really actually in the fall, but they're doing their little thing today.
That's exciting.
And there's people who've been longer than that. And there's a 25, there's a 30, there's a 35, there's 40.
Here in this program?
There's people, not this program.
Oh.
No. But there's in the college. It's not just this. It's the college.
Okay.
It's a little reception over
Have
it.
you been here the longest in the program?
Lisa Jordan's been here probably 10 years longer than me.
I don't even know who that
You'll
is.
see her in psych, Dr. Lisa Jordan. teaches
Oh,
psych.
okay.
Yeah. But then me.
Wow.
Then me. And then there's a whole bunch of people right behind me, like a year or two. A whole bunch. All right. Let's move on and discuss. And then I am going to take the last hour or so to very quickly go through the important points of the PowerPoint with you. Okay? But we're going to start with this. This is to get you and your brain away from peace onto med-surg. When you're talking about your case study, you're talking about med-surg, right? So your brain is on med-surg. And we want you to see one, do one, teach one. And by teaching each other, which I was seeing, you're learning it better than if you just listen to me talk, right? Okay. So let's start let's start with number 1. So everybody pull out your case study for competency 9, where it says critical thinking exercise. Page 123. All right. Team 1. Your hospitalized client with degenerative joint disease. Now, DJD is another word usually for osteoarthritis. Good. Tells you she receives Tylenol, acetaminophen, for pain only when she requests it. She gets very little relief from the drug and is sometimes unable to sleep due to the severe pain. The client states that she uses glucosamine at home. Glucosamine and chondroitin are actually available over the counter. Anybody know what they are?
Anti-inflammatory?
They're anti-inflammatory supplements. I think chondroitin comes from shark cartilage. Those you can look those up. Did anybody look up in your group here? Did you look it up?
Well,
What did it say?
It was right here. It
Okay.
decreases inflammation. The other one strengthens cartilage.
Okay. And usually they recommend, and some orthopods and such are not against people doing glucosamine and chondroitin, but it's important if patients taking a supplement or some kind of complementary herb supplement, etc., that they do what? That they tell the doctor or you that it's one of their medications, because these aren't necessarily safe things. And you'll do more with CAM, complementary and alternative medicine, and herbs and supplements next semester. But you've been studying that as part of people's medications all along, right? You know that some do interact with prescription medications or have side effects that are problematic for the patient. Okay, so people do take glucosamine and sometimes chondroitin with it for the anti-inflammatory effect of that. But it's not something that is a prescription med given by the doctor. The doctor there, however, needs to know. All right, number 1. Go ahead and read it. Who's going to present?
That's me.
Okay.
What should you include in our comprehensive pain assessment? Well, we just did the basic pain questions.
Which are?
Where is the pain? What type of pain? What alleviates the pain?
Good.
What stresses out the pain? The pain scale.
Okay, good.
When they take the meds.
Ah.
When do they take their medication? Is it around the clock, or is she only taking it when she feels bad? And then you could do some education on that. How
Okay.
if you have
Well, that kind of gets into the next ones.
Okay.
What option does she have for pain control? What interventions based on her pain assessment? So one of your interventions would be patient teaching.
patient teaching.
Okay, so what did you guys come up with for this patient teaching for her pain?
You shouldn't take your medication when it's already bad, because it's going to take a while to kick in. Her glucosamine, how is that affecting her treatment?
Okay.
If it said in the book that if you take it for more than 6 months and it's not doing anything, then you should
Okay.
discontinue, and you need to let your doctor know.
Okay, good.
It says also to monitor glucose levels when you take it,
Aha.
as well as be aware of the side effects, which include rash, GI disturbances such as diarrhea, drowsiness, and headaches.
Good. Good. Okay, there are side effects.
And
That was
then,
what I was alluding to. Good.
yes, and
Okay.
then some alternative ways to help her would be rest, hot and cold applications, positioning. It says make sure you keep your joints in the correct position. You don't want to keep them super flex or super.
So you want good anatomical positioning.
Elevate the legs if it's in her legs.
Okay.
Supportive shoes, and educate about weight loss.
Okay, if she needs it.
Yes.
It doesn't give you a lot of information, age, weight, any of that. But somebody with degenerative joint disease, what kind of pain do you think this is? Is this acute pain or is it chronic pain?
Chronic pain.
Chronic non-malignant pain. So she may need a pain workup. She may need a pain consult. She may need more than taking an occasional Tylenol. What does Tylenol do for inflammation?
It decreases inflammation.
Nothing.
Oh.
Nothing. Tylenol is not an anti-inflammatory. It's an antipyretic and an analgesic. It has no anti-inflammatory properties. I don't see her on any over-the-counter or prescription anti-inflammatories.
Yeah, it says for what options does she have for pain control.
Okay. Other meds.
We have topical agents, lidocaine patches, NSAIDs such as Celebrex, cortisone
Yes.
shots, and
Yes.
muscle relaxers such as Flexasil.
Okay. Flexeril, yeah.
Flexeril.
There are a number of other things that a pain consult may be able to offer her pharmacologically. So she hasn't really even started, she hasn't done any kind of aspirin or NSAIDs. Aspirin and NSAIDs, antiprostaglandins, are anti-inflammatories, aren't they? But it's better if you don't take them PRN. It's better if you take them around the clock. Advil, which is what? Ibuprofen. Aleve, which is naproxen. No. Advil is ibuprofen. Advil Motrin or ibuprofen. Aleve is naproxen. But you need to take them around the clock if you're trying to get an anti-inflammatory effect. Okay? If you have a little bit of pain and you're taking a couple of Motrins, which is ibuprofen for a headache, that's different. But to get the anti-inflammatory effect of aspirin and NSAIDs, it needs to be around the clock, which she's not doing even with her Tylenol. Tylenol's not an anti-inflammatory. And then there's a whole range of other pharmacologic things. That's why I said maybe a pain consult. If she's having severe pain, whatever that means, and you've assessed that, there's a number of things that she could do to help her with her chronic joint pain, right? Or her chronic degenerative joint disease pain. In addition to the meds. Did you want to add anything, Ms. Cooney? There's a lot of things. We really do need to be advocates for patients getting good pain management. There are hundreds of interventions that may be able to help her feel better. Now, non-pharmacologic is important too. If it's really bad pain, you can go up the scale, the analgesia scale. You can start with the Tylenol. You can go to the NSAIDs, aspirin and NSAIDs. You could go to mild, or if necessary, higher doses of stronger drugs. What's the strongest category of analgesics that we have available? Opioids. Right. And if somebody has severe pain and they need it, then they have severe pain and they need it. So that's where the advocacy comes in. We still have docs that don't want to give people a mild opiate because it's not cancer, We do better with malignant pain now than we do with chronic non-malignant pain. We do pretty well with post-op acute surgical pain, but that's not chronic pain. So people need to get what works for them, right? And then there's a whole host of non-pharmacologic things which you would talk about. In her case, warm water may help. You know, a hot tub, a gym with therapy pool. It is important for people to also exercise. Keep those joints moving. Good anatomical position in bed is good, but you want them out of bed, right? Okay, good. Okay, so this is really about chronic non-malignant pain, isn't it? And the nursing advocacy and management of a patient who really doesn't have very good pain management strategies. Okay, number 2. 59-year-old woman had rheumatoid arthritis for 10 years. Who gets rheumatoid arthritis? It says woman. We know that this disease is what? Autoimmune. Body attacking itself, right? And so it is higher incidence in women. What age group? Younger. Younger, actually. You can actually have juvenile arthritis. Have you ever heard of juvenile rheumatoid arthritis? Or they call it juvenile arthritis, but it's rheumatoid arthritis. Kids can get this autoimmune disease. And in the past, before we had some of the new medications, it was a very crippling autoimmune disease. Does it just affect joints, rheumatoid arthritis? No, it's a systemic disease like lupus. Whereas osteoarthritis is degenerative joint disease. Not that people aren't in pain, but it's not an autoimmune disease, is it? But RA is.
So for all 3 of these, is it just a specific age or is it age?
Anybody can get any of these diseases. I mean, I don't want you to think that you can only get RA or lupus when you're younger. It can happen any time, but the statistics show that it's higher incidence in women, any autoimmune diseases, and it starts in usually the childbearing years, and sometimes younger. Sometimes younger. Like lupus and RA work that way too, sort of the same. But kids can have RA. Okay. She's independent in her ADLs, but she complains of constant pain. She's taking methotrexate, Plaquenil, which is what? What's the generic name? Of Plaquenil. What'd you write? Hydroxychloroquine, yes. It's a quinine, isn't it? So originally we gave Plaquenil in countries that had what? Malaria. It's an anti-malarial drug. Good. Okay, Celebrex. What's Celebrex? You guys are back here. You looked them up. This is your group. What's Celebrex? Anybody know what Celebrex is? It's an NSAID, right? It's a COX-2 inhibitor, non-steroidal anti-inflammatory drug. We used to also have Vioxx and Bextra, and they took everything off the market, and then Celebrex is now back because it's supposedly easier on the GI tract than the other NSAIDs, but they were finding more cardiac problems. So, okay, so Celebrex is an NSAID, and then you do know what prednisone is. You don't have to look that up. What's prednisone? Corticosteroid, and it's given for severe inflammation. Okay. Her disease is still slowly progressing. Because of diabetes, she receives only a low dose of prednisone. Why? Because prednisone will increase your blood sugar. Right. Her husband died 2 years ago, but she has several children who live close by. Lately, her children have tended to ignore her because she's very moody, negative, and tearful. The word diabetes mellitus just came up. When we talked about the anti-diabetic meds last week, and we talked about the classifications of the oral hypoglycemic agents, the sulfonylureas, which increase insulin secretion, the metformin, the glucophage, biguanide, which decreases insulin resistance. If you're astute, you can hardly miss the commercials these days for this new class of anti-diabetes meds called gliflozins. This is dapagliflozin. The brand name is Farxiga. You're not going to get any brand names on NCLEX anymore. It's all going to be generic. Another one called Invokana is the same classification. These gliflozins are now working to increase renal secretion of glucose. Okay? So now we have, a couple that act on the pancreas, like the old sulfonylureas, to increase insulin secretion, which of course none of these meds are going to work on what type of diabetes? Type 1. None of these. You can't take any kind of pills if you have diabetes type 1 because your pancreas doesn't make any insulin. So the only thing keeping you alive is insulin. Okay, so for type 2 diabetics, this is who they're selling it to. They have this new category. Farxiga and Invokana are glipizins and they increase the renal secretion. So now we have another new category. I'm not going to test you on it, but as I said, you can barely miss the commercials because the drug companies are trying to make a lot of money on people that have type 2 diabetes that, want to manage their blood sugar. Another magic pill so you can eat what you want and not lose weight, right? Okay, but this is another new expensive group of anti-diabetic meds. All right, so what is this client's priority nursing diagnoses?
Pain.
Pain, yes, pain, alteration in comfort. She says she has a lot of pain, constant pain is not being well managed. Are there any pain meds in there, any actual analgesics? No. Okay. I mean, there's things for inflammation, etc. Okay, in addition to pain, what's next? What else did you come up with? Coping, yeah. Don't forget the psychosocial nursing diagnoses. She has pain, but she's also having a lot of trouble with other psychosocial things. What do you think she might be feeling? Depression. Okay, social isolation, if she's not getting out and about. Powerlessness, hopelessness, anxiety, all those kinds of things would be legitimate and important nursing diagnoses. Good. Okay. All right, she is independent, but she's got a lot of psychosocial issues in addition to pain. And so you said what factors are contributing to her emotional state. One is the pain, and then in addition to that might be if there's social isolation. Her children are now ignoring her because she is what? What does it say here? Moody, negative, and fearful. So you guys are in psych. You're studying depression. Depression is a what? Treatable disease. And so she may need to have a psych consult or somebody to talk to, maybe just a counselor, not just, maybe a counselor, and maybe she might need medications for that. But again, we're not going to throw more pills at her until we know what she needs, right? Okay. Right. She might need some counseling. Somebody to talk to because her children are getting burned out, right? That happens. What outcomes are desired for this client? A couple things pop out. Pain management, good. What else? Management of her diabetes, good. That's really important. Management of her depression or her emotional, support for her emotional issues. Okay.
Does she continue to be able to perform her ADLs too?
Yes, maintain her function, absolutely. Her independence as long as possible. There may be some individual and family coping issues here, right? Okay. You all have families, right? Okay. Anything else you want to add there? It says, now the meds. Okay, teaching plan. What do you teach her about the prednisone? Prednisone is a steroid.
Monitor her glucose, control her diabetes, take a calcium supplement to prevent osteoporosis, and get a bone density test.
Bone density, good. Okay. Control infection. Okay, so all of these are relating to the side effect profile of steroid use, right? They have her on the lowest possible rate to try to still keep her A1Cs managed. All right, so they're all of the things they need to know about steroids. Can she stop it suddenly? No, why not? She'll have adrenal insufficiency, right? It suppressed her own endogenous corticosteroid production, so she has to wean down from whatever dose she's on. She still has to wean off if she's been on it for a while, or she can get really sick. Okay, and then there's diet issue that goes with that and all of that. What about the next drug? Tell me about Plaquenil. It's a malarial agent, but that's not why she's getting it. Why is she getting it?
It slows the progression of the rheumatoid disease.
Yeah, it actually shows, and they use it for lupus too, don't they? Very good. It's pretty safe. What are some side effects?
Stomach discomfort.
Retinal damage. Okay, it can bleach the back of the eye, the hair, that sort of thing. So they have to have eye checks. Stomach upset. Okay. Otherwise, and most ophthalmologists will tell you you have to give a really high dose to get the retinal problems. So generally in low doses it's pretty safe. They usually give like 200 milligrams in a tablet. Okay, so she's taking that, and that actually helps with the autoimmunity. It actually decreases the autoimmunity. That's why they use it in lupus too. What's the next one on there? She's taking Celebrex, which we talked about, COX-2 inhibitor and NSAID, which helps with pain and inflammation, along with the prednisone. And then the last one there is, okay, methotrexate. I'm sorry, I didn't do the methotrexate first. So what's methotrexate? What is it actually?
Immunosuppressive drug.
Yeah, it's an immunosuppressive. We actually use it, it's actually an anti-metabolite used in cancer treatment. Methotrexate is one of the anti-metabolites, like 5-FU. So it actually is an immunosuppressant, as are other chemo drugs that are cytotoxic, but that's the downside too, isn't it? What does that increase the risk of? Infection. It can lower her white count. She can get neutropenic. She can get myelosuppressed, like with other chemo drugs. Rumitrex is a very low dose oral form of this chemo drug, which if we give it for cancer, it's usually IV and in a higher dose. Okay, like they see with kids with leukemia and such. All right, next group. Lupus group, number 3. 32-year-old female visits her physician's office with complaints of a facial rash. On further questioning, she's been very fatigued and has joint pain in her ankles and knees. Her infant son is 4 months old. She has stopped bleeding from her vaginal delivery, traumatic vaginal delivery, because he was 10 pounds. When obtaining a complete history, what other questions should you ask the client? What risk factors should she have for lupus? What lab tests will be ordered? And what type of health teaching will she need? Who wants to present? Okay, go ahead. Speak up.
Asking her, the additional questions we can ask her is when was the onset of the rashes? And we'll ask her when the bleeding has stopped, because it didn't specify when it stopped.
What said it stopped?
It stopped, yeah.
It said she stopped from her vaginal delivery. Okay.
Yeah.
Because you want to know about
We wanted
possible
to know-
coagulopathies or something?
Now, we wanted to know if,
Okay.
for the systemic lupus, because we have two kind of lupus. Right?
Most
We have
of
the
it is systemic. Yeah, most of it is
and the
systemic.
skin one. Since she came in with this facial rashes,
Okay.
we wanted to know if it's specific, how they call that one?
Discoid?
Discoid.
But you
or
can
is
have
it
the
systemic?
facial rash for either
For
one.
both,
Right.
yeah.
So let's say it's systemic lupus. That's the most common.
Okay.
But she has other systemic symptoms in addition to the rash, doesn't she?
She has fatigue.
Right. That's the
Yeah.
autoimmunity, the fatigue, the joint pain, all those itises in addition to the facial rash. Okay.
Yeah.
Yeah, so it's systemic.
Yeah, okay. There is factors.
It's because she's a female.
Gender, the gender, age.
Right, because we say that autoimmune diseases are higher incidence in women. Not sure why, but it is.
Yeah, she's
Lupus is
young,
9 to
32.
1, women to men.
9 to 1.
9 to 1. I know a man with it, but it's much less common than men. Okay, go ahead.
And she's 32, so
Yeah.
she's in childbearing age, so she's still young, so the
Okay.
age has a factor.
Yes.
Is a factor.
Yes.
The
Lupus
genetic
is
component.
highest in young women. Actually, young African American women are at high risk. Although I know women who aren't African American, but it's 9 to 1 women, and autoimmune diseases are highest incidence in young adults and childbearing women. Okay, that's genetics. Genetics. Yeah, family history is important too for a lot of these things, but not always. A lot of people don't have anybody, so we don't know what caused it, do we? Okay.
In her case, it looks like it's just a new, she just being diagnosed with it. It is a new.
New diagnosis postpartum, yes,
Yeah,
yes. Whether or not the pregnancy stimulated something, that's certainly possible, but it doesn't specifically say that. Okay, all right.
Then the labs.
The labs.
So, yeah, we'll do CBC on her.
Mhm.
We'll do skin biopsy.
Okay. Blood test.
Yeah.
We don't necessarily do a skin biopsy if we don't need to. The blood test, it's called a rheumatology panel, isn't it?
Yeah, then rheumatic factors, it says.
Okay, in the rheumatology panel, now they're gonna do a CBC too, which is what?
Complete blood.
Which is her red cell count or white cell count or platelet count, because there can, with some of these autoimmune conditions, be some decreased production of cells. But the rheumatology panel has a couple major things. One of them is the ANA. Anybody know what that stands for? Did you see that in there? Anti-nuclear antibody, exactly. And you see that in some of these autoimmune connective tissue diseases. It's increased in lupus, it's increased in RA, and some of these other less common ones. Because remember, there's like 100: polymyalgia rheumatica, ankylosing spondylitis, polymyositis, dermatomyositis, etc. Anti-nuclear antibody. Now, they can also do things like double-stranded DNA. You know, they've got a lot of things they can do. They can look at the complement, the C4, and that's actually decreased.
C3 and C4.
C3 and C4. The complement is used up in autoimmunity, so that will be decreased. Yeah, you were a lab guy. But this, a lot of, you know, pretty sophisticated tests that a rheumatology panel can look at.
And they say they can do the electrophoresis too.
And serum protein electrophoresis, which looks at, you know, do they have abnormal IgG, IgM, IgA? All those proteins are abnormal as well. But the rheumatology panel, there aren't normal people with increased ANAs, or meaning they don't have one of these conditions diagnosed yet. But it is diagnostic for a lot of these autoimmune connective tissue type diseases, anti-nuclear antibody. That's one of the labs they'll definitely do. And then they might look at other things too, of course, the chest x-ray, etc. Okay, go ahead.
What they will look into ESR.
Uh-huh.
Yeah.
What does ESR tell you? If you have an increased erythrocyte sedimentation rate, or just an increased SED rate, sometimes you'll hear.
Inflammation.
It's a general measure of
The blood is
SED rate. Increased erythrocyte. How fast does it fall? How fast does it sink to the bottom of the test tube? It's just a general measure of inflammation. Inflammation. Right. Yeah. So a SED rate for people with an inflammatory condition would be elevated. Okay. ESR or SED rate. Okay. Anything else on the labs? It really depends then on other symptoms. And it doesn't give you a lot of that. Obviously, it's important because she's developed this disease and she has a small child to take care of.
they talk about syphilis too. They will look into something.
They used to do that, it's an older test, but they would actually have a false positive syphilis test. They don't have syphilis, but they have, the test is positive. So they would use that as part of the picture. It's not, doesn't mean they have it. Don't see that as much anymore. Okay. Health teaching. Let's look at the nursing care plan.
Patient with this disease, you tell them to avoid excessive exposition, to expose themselves, not to expose themselves to the sunlight.
Okay. So what is this disease called? You can just give me the short version. She has lupus, right? SLE, systemic lupus erythematosus, which is why we say lupus. Lupus is the Latin word for wolf. And all that meant is when they first identified this butterfly rash, this malar rash, it looked like the face of a wolf. So it's systemic lupus erythematosus. SLE is the acronym. Okay. All right, so somebody with, say, lupus, okay, say it. Say the disease, don't just say this condition. We'll make sure we know what we're talking about. Okay, so patient with lupus, go ahead. You're fine.
Do not expose yourself to
Right,
sunlight.
right. They're photosensitive.
So you have to put sunblock, you know.
Sunblock,
Yeah.
long sleeves, a hat, if they're in the direct sunlight, right?
Sunlight, yeah.
Because
Avoid-
it can do what?
They can get burned.
No, it can make their symptoms worse. It doesn't burn them. It increases their symptoms. It just makes them feel worse. If they have fatigue, they're more fatigued, etc. Okay.
And then avoid, crowd because they will be on the immunosuppressive.
What's the main medication we give for lupus? Still today, the main thing we give people is a lot of what? It's a very severe inflammatory condition. So where am I going here? Steroids, prednisone, steroid treatment. But what is this young woman going to hate about her prednisone? Weight gain, fluid retention, mood swings, all of that. So it does immunosuppress her, which we want in autoimmune diseases because autoimmune is hyperimmune. It doesn't mean their immune system works better. It doesn't. But we want to suppress the autoimmunity. And then we also have a lot of itis, a lot of serositis, inflammation of the serous membranes that surround the joints, the heart, the lungs, the kidneys. So what are some people that are unfortunate enough to have organ-damaging lupus, what are some of the organs that could be affected? The kidneys, lupus nephritis, one of the causes of chronic kidney disease. Lupus nephritis. They treat that pretty aggressively now. They have some new drugs. When we do drugs in a couple minutes, after I give you a break, we're going to talk about the biologic agents. The biologics or the biologic response modifiers. They're not that many years that we have had these. And they really revolutionized the treatment of rheumatoid arthritis, where people got crippled up and looked like this. It now can prevent the joint destruction. Anybody seen any commercials for some of these biologics they use? Enbrel, Humira. Yeah, Remicade. They have one now for lupus. Took them a long time. They do have a biologic for lupus now because this is a new way to treat inflammation and autoimmunity and connective tissue diseases. They're very expensive. They're only given mostly by infusion or injection. Some insurance companies don't want to pay for them. And guess what they do to the immune system? They suppress it. So what's the risk? What's the side effect? Infection. So don't they say that in the commercial? Yeah. Don't take Remicade, Humira, Enbrel, or Encia, Kineret if you have an infection, because it could make, then you could get septic because you're immunocompromised from the drug. Okay.
It says advanced to cleanse the skin with Mysol.
Okay, the skin manifestations, if they have skin. Some patients with lupus don't have any skin things, but if they do, mild soap.
Avoid dry, powders.
Okay, all right. So that's sort of like basic, take good care of yourself.
Yeah.
Healthy diet, manage weight, especially when they're on a lot of prednisone. I mean, these people can be on 80, 100 milligrams starting out if they have, especially if they have retinopathy and retinitis, vasculitis of the brain, CNS symptoms, nephritis. So if they have a lot of serious itis, they'll put them on a lot of prednisone. And then what will they want to do? Wean it down to the lowest possible dose that manages the disease. Okay?
She might have hair loss too.
Possibly. People, they can have their hair fall out. So there's a whole constellation of what we call constitutional symptoms related to this autoimmune connective tissue disease. So that's this chapter. This competency is about connective tissue diseases. There are other autoimmune diseases, Crohn's disease, ulcerative colitis, type 1 diabetes, etc. But we're talking now about connective tissue. Anything else you guys wanted to add? We talked about it? You had some really good discussions about it. About the OB is sort of thrown in there because that kind of gives you a picture of how old she probably is. All right, very good. So you're going to teach her about her medications too. You always do medication teaching. So you need to know the meds, why they're getting them, the side effect profile, and what to teach. Number 4. You're caring for D, an 86-year-old woman. Somebody asked me, do they do knee replacements on 86-year-old women? Well, the answer is yes. If you're on that joint spine unit in Arundel, they got people in their 90s. They're doing their second or third hip or knee. If they feel they need it and it's going to help them move better. She has rheumatoid arthritis, which she may have had for a long time, right? They took over Neil. Okay, you're hearing. Her 4 adult daughters have been concerned following Dee's recent surgery. Some of these patients go to rehab from the hospital, right? If they need some nursing care, PT, etc., they may go to your rehab center. She's home now. So the 4 daughters took over meal preparation and housework. Dee says she doesn't want to be a burden to her family. Her arthritis has severely affected most activities using her hips and knees. Dee recently moved to a new condominium after selling her home of 50 years. So now she's in a new setting, too. A year ago, Dee experienced a myocardial infarction, which is what? What causes that? Well, it means that something plugged up the coronary vessels, the vessels that perfuse her myocardium, and infarcted some of her tissue. Ischemia and infarction, which is worse, the part of the tissue that's on her heart has died, right? Okay, so she's at risk for heart failure, etc. She has chronic anemia, hypertension, and decreased vision. Prior to this surgery, her quality of life decreased due to her inability to walk and the control her daughters have taken in assisting Dee to manage her home. So she's in a new place, and hopefully it's a 1-level condo, which may be good. But she's got all this, she's got this new setting. Doesn't sound like she's real happy about her daughters taking control of her of her life, they're helping her in their well-intentioned way to help her. Okay, so go ahead, guys. Explore outcomes the nurse and client may pursue. What did you come up with? Who wants to present? Okay, go ahead. You got 5 minutes.
Inability to do what you're supposed to do. So we collaborate with the nurse, we collaborate with the patient, and other healthcare team.
Good. Other healthcare team. Bring in other interdisciplinary collaborators.
Come and assist her so that you will be able to walk
Okay.
with assistance so that you can be able to do whatever you're supposed to do.
Right, she's had this knee replacement, but it says her quality of life decreased due to her inability to walk. Now, that's kind of a red flag for me. Did the knee replacement work? You know, why is she now at home? Is she getting home PT? What is she still doing to try to walk? Okay. Okay, so you mentioned other people in the team. Not just nursing, but nursing also has home health aides, other people that could be maybe brought in. Okay. Doesn't talk about her insurance, but she's 86, so some things can be provided by Medicare. Okay. Go ahead. What else did you want?
How to manage your pain.
Okay, good.
Going to be on pain.
Initially, it's very painful. Yeah, it doesn't say how many days or weeks or months she was post-op, but let's assess that. Nutrition therapy, good, good, good. So that she can maybe do some of her own meal preparations and cook and healthy food with assistance perhaps. What else?
And for, in terms of activities, you also need your physical therapy. Therefore, either be using a cane or crutches or weight or wheelchair. Because the problem now is she gets a history of heart attack and
Right, she's had an MI, that's it.
MI and dizzy and she also has hypertension.
She has a lot of risk factors for what?
For
For fall, for injury.
so maybe she should be end up to use a wheelchair in the end. And for labs, we want to make sure all the diagnosis is already taken care of. For example, for anemia, we'll do a CBC every 3 months to make sure the
And what can we suggest for her because of the anemia?
in terms of
Diet,
okay, in terms of the
it says she's
anemia.
anemic, yeah.
Okay,
Diet, maybe medication.
multivitamin medication too. Multivitamin.
Okay, iron, folic acid, okay.
They also will do a EKG or 2D echo to monitor her heart.
That's right, you could use an echo to look at her heart function. We want to make sure that that's not contributing to her inability to move around, okay?
And for decreased vision, these are all risk of fall. So we need to do maybe a consult, only the consult to see what actually wrong with that. Is it glaucoma? We don't know what was actually decreasing
Right. It
her
doesn't
vision.
specify, but you need to be very concerned about her vision.
Yes, yes. So
Absolutely.
it should not fall.
Because that can affect her independence and ADLs also. Okay, anybody else? What did you guys come up with?
Then for
Number 3.
in terms of the knee, in terms of preventing the, we can use a knee brace.
Okay.
A knee brace so you can immobilize the knee or make
Maybe.
sure. Yes. So
We don't really want them to have that forever, but yeah, you want initially, they'll give them something to do that post-op. Okay, protected. Also, we're concerned, what is a really big risk for this lady with her type of surgery and her immobility? About DVT. DVT after a knee replacement. What are you going to check? Isn't the nurse going to check her neurovascular checks of that foot to make sure? Because she's not moving, and so all of that needs to be, it's a holistic, it says holistically assess. So you're assessing her whole psychosocial and then head-to-toe assessment, her risk factors for falls, for DVT, et cetera, because of the knee surgery she just had, right? And then what's energy conservation mean to you? Joint protection, you want to protect that joint from fall, from trauma, from complications. right?
Yes, we'll make sure she rests the knee.
Well, she also has RA, right? It says she has rheumatoid arthritis, so we want to protect the knee. But energy conservation is a concept that's important for people with autoimmune diseases, because what is one of the important, common, ubiquitous symptoms of autoimmune disease? Fatigue. Fatigue. So you want to what? alternate periods of activity, which she needs, with periods of rest to conserve energy. So she remember the MS question? You don't want to do all the work in the morning and then ruin the whole rest of your day. You want to alternate activity with rest. RA is autoimmune, lupus is autoimmune, MS is autoimmune. So energy conservation is just that. Waves, assistive devices to help her to be more independent and conserve energy around the house. And then maybe somebody for her and her family to talk to, right? You know, a counselor or somebody for them to talk about some family issues. I mean, who knows? Maybe she's not really going to be able to stay in that condo. Maybe that's not the safest place for her.
You don't want the condos on the second or third floor.
We don't know. Yeah, there's a lot of ifs. Maybe it's fine. Maybe they can get the home health assistance and keep her in her, and she can stay in her home, and maybe not. Right? All right, everybody give yourselves a hand. Good job. By the way, I wasn't just tormenting you. Mr. Armstrong's group just did the same thing, right? And present, because that pulls it together and you learn from each other. All right. Because there's a lot of words here, here's your objectives. I'm really just going to hit the high points, but first you're going to get a break. I almost forgot your break. 15 minutes, and then we'll have an hour when we get back. I see 10:20. We'll start at 10:35. And you can pull out whatever you've taken off Blackboard or your study guides for the PowerPoint. Okay, good. Good sharing, good discussions.
I'm hungry.
So, what do we do now?
I know.
So when we go through these
It's a lot.
conditions, you've already
I mean,
been
what,
introduced
for
to them
that?
and talked about them.
Beads.
Does anybody else have an absence for clinical? Now, most of you are doing the Kaplan case study, which they now call on their homepage a mid-fidelity simulation, just so you can't find it. It's called a mid-fidelity simulation, and it's adult diabetes type 2. That's our rotate out assignment if you're in a clinical group where there's too many students for the unit. And you guys are both in that situation. So that's actually a clinical day assignment. So if you're already doing that, and you miss a day, and you need a clinical makeup assignment, see me. Most, Miss Oliver and Miss Jeffrey are both really good about emailing me and telling me somebody was absent and they need a case study, okay? If you miss a lab, Miss Diaz knows, believe me. She knows.
She'll hunt you down.
Oh, yeah. And she'll send me emails to find out if I gave you a case study for your lab absence and did I get it back and graded it and are you cleared. So if you miss a 2020 lab, which believe it or not, the attendance has been fabulous this semester. We've had like nobody out. Nobody. So you learn maybe the hard way, I don't know, but that it's important to come to lab, that you'll have a makeup assignment. And the makeup assignments are related to this course. That's the point. You know, Jessica's makeup assignment is a lady with thyroid disorder. I have a whole bunch of oncology case studies because after test 3, we'll start in all the oncology nursing stuff, okay? But if you miss a lab, just get a case study from me. I don't care whether your lab is Monday, Friday, whatever. And if you miss a clinical, then see me also. But hopefully you won't, now that it's not snowing anymore. So maybe a little bit of a dry. I don't think it's going to be enough to cancel clinical. Yes. Michelle said she thought you could. So you tried recently. All right. Dr. Dixon, make sure you send her an email. And I will also see her tonight because I do 2032. She'll be here tonight. But email her. She does she has her cell phone like attached to her body. And if you text or email her, she'll see it right away. Well, you know, a lot of you guys have your cell phones attached to your body.
This day.
I grew up where we didn't even have any cell phones, and if your car broke down, you walked to the gas station. Yes.
Did you get my email about the case study? Maybe I didn't.
Yes.
Okay. I couldn't.
Yes.
That.
That's fine.
Okay, but I
I did.
Okay, I took.
You did.
pictures. I did. So
And
I
you have a
didn't know-
screenshot. That's all I
Only
need.
of the last 2,
That's okay.
because I didn't think about it.
I
the
trust
first time around. Okay.
You could take a screenshot. She had done it before, and it let her do it again, but it wouldn't increase her score from when she did it
But
before.
I did really good this time.
Yeah,
My
you wanted
score
me to
comes
see
up.
that.
Yeah, my score comes up.
Take a screenshot, show me. No, if you didn't,
Well,
that's
I
fine.
only did it in the last 2 parts of the case study. 'Cause I didn't
That's
think
okay. It's a big deal case study, and you really all should do it. And if you want to do it for your clinical makeup, it doesn't have to be the day that it says on your clinical rotation. It can be, but it's actually might help you on the test next Wednesday because it's on diabetes type 2. So who's done that case study? It's a lot of work, isn't it? Yeah. Okay. But that's not the point.
It's okay.
Those of you who did it and found out it was a lot of work, did you learn something?
I
good.
did a lot better this time. than I did
Okay,
last
well,
time.
see, you learned
Too much
something.
amount of work. It was
You can
like
do it.
time consuming. You had
It's
to
very
really-
time
You had to
consuming.
really actually think about what you needed to pick. And
Right.
do. So
It's
it was-
a virtual
it was a learning
patient.
curve.
Yeah. Good. Thank you, Steve. All right. Don't yell at her. She liked it. Okay. Connective tissue diseases. So we're talking about musculoskeletal. I'm not going to read every word on these slides. Number one, there's 82 slides, and we have an hour. But you have it on your PowerPoint. You have it in your study guide, and you can go back and look at the PowerPoint as you study. I did not develop this PowerPoint. It's very good. It's very thorough. There's some cool pictures. There's a lot of it's the references are all cited at the end. There's some links. But I am going to zip through it with specifically stopping at the slides on things like medications that are important for you to know. Okay? There's concepts as opposed to words. You don't want to memorize the words, you want to understand the concepts, right? So we did mention in many of these case studies you just talked about the concept of chronic non-malignant pain. And the quality of life can be hugely impacted by chronic pain, right? And you talked about assessing where it is, what it feels like, what makes it better, what makes it worse, in addition to that magic number. But the magic number, meaning the pain rating scale, 1 to 10, is just intensity. It doesn't tell you everything about pain, does it? But it's still the 5th vital sign. Okay. There are, in some of these connective tissue diseases, particularly rheumatoid arthritis, there could be joint deterioration. I've seen people with severe RA who've had a lot of joint replacements. 1 in 6 people have one of the 100 types of arthritis. So as you go through your chapter, it's going to talk about other connective tissue diseases. We're going to do OA, osteoarthritis, degenerative joint disease, a wear and tear disease. There is a familial tendency. I'm starting to get it. My mother had it, my grandmother, my great-grandmother. Probably going to get it. As opposed to RA, lupus, and some of these other autoimmune conditions that I mentioned. You don't need to know the others. But they all have a lot of the same characteristics and therefore the same nursing care plan, right? All right. And that keeps the rheumatologist busy and some of the orthopedic surgeons, and now there's a huge industry around joint replacements. Come a long way. Osteoarthritis is the most common. Talked about it being BJD. There is deterioration and loss of cartilage. So what joints are affected most in OA, osteoarthritis?
Knee
Weight bearing. Which one is the hinge joints? The knees. Also the hips, your weight bearing joints. So what would be putting more weight on your weight bearing joints? What would be a risk factor? Obesity. And family history, and of course the athletes who have beat up their knees playing basketball or football or whatever, their knees, their hips, and all other parts of their body, including their brain, which is another controversy right now, but we're not doing that today. You can have a primary osteoarthritis, or you can get joint inflammation secondary to other conditions. And it's nodule or non-nodule, don't worry about that. Some people have these little nodules that pop up on their skin. Here's a picture at the bottom. We can hit one light if you want. But again, this is in your, because there are some cool diagrams, charts, and pictures. This is in your Blackboard. You have access to all PowerPoints. All right. Shows the thinning of the cartilage, the destruction, some of these osteophytes that can form in the joint spaces. And it's inflammatory. They can have inflammation of the synovial fluid, which is the cushion, or they can lose that. They can have some dislocations and some deformities that develop. This, of course, is the vertebral column, which is also weight-bearing joints. I forgot that. you have your knees, you have your hips, you also have your vertebral column. And in people, if somebody has something like osteoporosis, then that's just a further risk factor that they could develop a secondary osteoarthritis. And then people's spines start to collapse, don't they? All right, so here's some risk factors. Age, genetics, obesity, trauma, occupations. Occupations like nursing. Yeah, exactly. Years on your feet, pushing heavy things around. Please protect your back. Please protect your joints. Make sure you use good what? Body mechanics. Really important. And now they have some of these better lift devices and the thing above the bed that lifts patients and use those. And then people with lack of exercise, just makes your muscles weaker, makes your joints more at risk. 3/4 of people over age 55 have some kind of joint changes. Men above 50, it's more likely in the hip. Women above 50, it's more likely in the hand. They can also get some hand arthritis, which can make it difficult to open jars, etc. Crepitus, that little crunchy when you push on it under the skin. Don't worry about Heberden's nodules and Bouchard's nodules and all that sort of thing. But there's a picture there. The Heberdens are towards the end of the finger. The Bouchards are further back on the finger. But that's you can have these little bumps that form. And of course, then there's all the psychosocial things regarding chronic pain and anything that affects mobility and ADLs. Pain can affect sleep. Obviously, here's some other diagnoses related to somebody with arthritis. And this goes for pretty much every condition we talk about in this competency. And this is where you see a lot of this if you work with long-term care patients, the elderly, etc. All of these things can happen to anyone at any age that has one of these connective tissue diseases, right? Okay. All of those would be relevant potential nursing diagnoses for arthritis or other connective tissue disease patients. You can see the body image thing, right? Okay. Diagnostic studies. Very important for the primary care provider to get a really good history and physical. You know, the chronic pain, how long have they had it, what makes it better, what makes it worse. Also then a physical exam. Some of these conditions, it takes a while to diagnose. Some of these autoimmune diseases can kind of take a while to manifest, and people can have these symptoms and not necessarily show anything on the blood test yet. But they can do CTs, X-rays, MRIs, bone scans, all that sort of thing to look to see if it's what type of condition they're dealing with. We talked about the SED rate, the increased erythrocyte sedimentation rate. Good, you guys brought that up. That's a general blood test for inflammation. Doesn't say where. The C-reactive protein is another thing that builds up in inflammation. They actually show that in things like myocardial infarctions and strokes too. But people that have these autoimmune conditions connective tissue conditions have a lot of inflammation. The synovial fluid can be looked at. They can take a sample from the joint and test it. They can also put things into the joint to try to manage the pain. What do they put into joints sometimes? Steroids, maybe some lidocaine, which is an anesthetic. Right, they can put things into the joints to manage pain. Obviously, some of you guys back there mentioned it's important to have collaborative care, to work with other members of the team. We want to have normal weight if possible. Avoid risk-seeking activities, jumping out of airplanes and such. George Bush did it on his 90th birthday. He didn't look like he landed all that well either, although somebody was holding him. I didn't think his wife looked particularly thrilled with the whole concept, but she kept her mouth shut. What are you going to do, right? Some of these guys that are, fighter pilots and stuff, I used to hang out with them in the Navy. It's a certain kind of personality, so there's probably not much you can do. But obviously we talked about spinal cord injuries and the age and gender of those guys mostly. Medication therapy with the pharmacist, with the prescriber, understanding the meds, managing the meds, taking them correctly, knowing the side effects. You all know about medication therapy management. That's what a lot of the NCLEX is now. What does a nurse need to know to safely and competently administer and manage medications? TENS units, transcutaneous electrical nerve stimulation. Some people find that helpful. They put it on the painful area, it gives it a little bit of stimulation. And there's all kinds of other complementary, I think is the current word, complementary therapy. Complementary and alternative therapies for people with chronic conditions, especially if they have a lot of pain and inflammation. And what are some examples of that? Well, we talked about supplements and herbs. People can take glucosamine and chondroitin, other things that, you know, they feel might help. Massage therapy, wonderful. Acupuncture, acupressure. I've tried it all. I have fibromyalgia.
Aquatherapy too.
Aquatherapy, wonderful. Warm water, yeah. They have these people with arthritis can exercise classes. I know at one of the gym in Bowie that I belong to, they have a therapy pool. They do they have arthritis aqua classes in warm water. Okay. I also do Reiki, which is like it's a bioenergy, energy healing,
Yoga.
chakras,
I can use
yoga,
all
very
that.
helpful.
Right now.
You want Reiki? You need some Reiki?
I need all
I'll
that
put the
right
peace,
now.
put the peace symbol in. Anyway, yeah, anything that makes you feel better, right?
Yes.
That's not going to damage you. You have to go to, know what you're doing and go to competent people, etc. But massage saved my life when the fibro was bad. All right, meds. Acetaminophen is Tylenol. Tylenol is an analgesic and an antipyretic. What's an antipyretic? Fever. Some people with autoimmune conditions, when they get flares, exacerbations, not so much osteo, but the autoimmune diseases, they can actually get a little fever from their immune system. But it's not an anti-inflammatory. We have topical salicylates. You guys mentioned that, like the Aspercreme kind of things. Topical means it's on the skin, the joint, for example. Non-steroidal anti-inflammatories, there's 22 of them. We know about ibuprofen, we know about naproxen. Celebrex is a COX-2 inhibitor, it's still an NSAID. Anybody can think of any others? Well, it's okay, any kind. Okay, that was just going to go for that. So say this in 1 second. What is the only NSAID you can give IV or IM? The others are all PO. And the answer is Toradol. Toradol. Toradol is used as an adjunct sometimes. You can give it with opiates. You'll see that in post-op care and that sort of thing. It's an NSAID, so it does help with pain and inflammation, and it can be given IM or IV. Toradol, not to be confused with Tramadol, which is Ultram, which is a mild opiate. Toradol is an NSAID. Okay, and then there's all kinds of others: Voltaren, Relafin, etc., etc. There's a bunch of them, and those are all prescription. People can put things into their joints. They can get hyaluronic acid, glucosamine, chondroitin, MSM, which is a sulfa. Lots of other things people think can help them feel better. And then you mentioned Flexeril. Flexeril and other muscle relaxants. Understand, people taking muscle relaxants shouldn't be driving around in their car, because you turn into Gumby. Everybody ever seen Gumby, the green guy? That's what happens when you take muscle relaxants, right? So it's going to be hard to function if you're on your Flexeril or your Soma or your Valium or whatever. But that does help somebody that is really in trouble, really in pain. Surgery. They can do an arthroplasty, go in with the scope and fix things, or they can go in and replace the joint. This is a prosthetic knee joint, a hinge joint, as you said.
Is there any way you can replace the cartilage?
I haven't heard of cartilage replacement. They're going to put the prosthesis back in, and then they're going to do intensive physical therapy to, increase range of motion, get it flat, get it to 90 degrees or better. But they really can't kneel after they have a knee replacement. I just went through that one myself. So he's going to get the second one done in a couple of months. He really can't kneel on that because there's really nothing above it except a little bit of subacute tissue underneath it. The cartilage that's gone is gone, but they can get really good function. And the important other part is the muscle strength. You gotta be able to get yourself up from a sitting position post-op, right? That's why some people have to go to rehab, because they can't stand up on their own to get to the bathroom. Okay. And then osteotomy would just be an incision to go in and realign. That's not a replacement. So a total joint replacement, this is the knee. Indications are somebody whose knee no longer functions and they have terrible pain. OA, RA, that's osteo and rheumatoid arthritis, congenital problems, trauma. A lot of these athletes end up with this. Osteonecrosis, if they have death of bone, maybe from osteomyelitis or whatever. If somebody has a current active infection, they won't take them to surgery for a joint replacement. If they have really bad osteoporosis, it's not going to work. It's going to break. Or other severe inflammation, they would need to deal with that first. Total hips, most common in people over 60, but anybody can get them. We have to be concerned with the elderly because we are doing them on people now who are 70, 80, 90. They're actually doing an anterior approach now where there's not as much of the hip precautions that are necessary. But you still have to know hip precautions and teach it to your patients. We're still doing the other approaches, the lateral and posterior. Physical therapy pre-op, show them with a prosthesis, talk about their risks, give them written instructions. There's a whole package you get from Anne Arundel if you're going to get a new hip or knee. They do over $1,800 a year. It's a huge, huge service line. They may get an IV piggyback, broad spectrum antibiotic as they're taking them into the pre-op. They may put in antibiotic beads. Some docs do that. Usually, well, no. Sometimes it's general anesthesia, a lot of times. But they also can do the epidural anesthesia or even some more local types depending on the patient's risk profile. Okay, post-op. Here's the post-op hip. The post-op hip, post-op care, post-op prevention of complications. Well, you know, I guess the worst thing that could happen, although these other things could kill you too, what the doc really doesn't want is a dislocation. They may have to go in surgically and put in a new one or fix the one that's there if it pops out. This is a hip. So a hip is what kind of joint? Your hip. Ball and socket joint, right? Okay, so everybody stand up. I gotta wake up. All right. Find your hip joints right here. Now I want you to put your legs apart. What do we call that? We call that abduction, right? Abduction. And that's why we put these little abduction or wedge pillows between the legs after a hip surgery, after a total hip. Why? We want to push the ball further into the socket, right? Now cross your legs like this. Now feel your hips. Boop. You see how that would be a position for dislocating that hip? That's why we tell the patients don't cross your legs. Sleep with the pillow between your legs or your wedge pillow. You want to maintain abduction and you want to prevent adduction. So you don't want them like this and you definitely don't want them like this because that can increase the risk of popping out, which is dislocation. So and the other one is flexion. I won't make you do that. If you're sitting like this, you're probably okay. If you're sitting like this, it's too much flexion. So a higher chair.
I had a patient where she, with confusion, wouldn't keep the pillow in between her legs.
Yeah.
And her foot is externally rotated.
That's bad. Yeah, because she wasn't maintaining proper position post-op. Why did she get it? Oh, because she broke her hip.
She fell, she rolled
She
out
fell
the
and
bed.
broke her hip, and they had to do something. So a lot of times now, they'll actually put in a new hip. It's better for these old ladies to get a new hip.
And I have one that had a hip replacement. She's up running around.
And she's
I had-
fine. Right.
Fine. Had one with, she fell in her C, I think the doctor said C3 and C4 was
fractured.
Fractured. She took the neck brace off and had it on this hat.
Okay.
And
Well, she's lucky.
She's
Could've been fine.
97 years old, and you
No,
would never
leave
think
her alone
anything
then.
happened, and she's running around like she never had nothing done to
Yeah.
her.
Well, everybody's different. Some of these people come out of these surgeries and, you know,
Strong.
6 weeks later, they're perfectly fine. And some people, they get a dislocation or they get an infection and they have to take it out. Give them 6 months of antibiotics with no hip. Take them back and put in a second one. I've seen that. Or they get, God forbid, a DVT. I saw that once. I mean, so there's a lot of things you're preventing in your post-op care, but you know, what the final outcome is has a lot of variables. Yeah.
You know that.
And age is not always one of them.
You know, like they say, like you fall and break your hip. Isn't it usually you break your hip and that's why you fall? Isn't that what it normally?
No. A lot of people fall for other reasons, and then when they hit the ground, they break their hip. It's usually when they hit the ground they fracture, especially if they're 90 years old and have some osteoporosis. Yeah. But anybody can fall hard enough to break their hip. Yeah, I had a friend that was a little younger than me, and we were coming out of church, and she slipped on the ice and broke her hip right there when she hit the ground. Yeah. Okay. All right. So you want to have abduction and prevent adduction. That's why I tell them to cross their legs, and you don't want to have hyperflexion beyond 90 degrees. This is 90 degrees, but they're not ready to be in a low chair with hyperflexion. They need to wait for the healing before they do more range of motion. You want to get the range of motion back. Infection, obviously, when you see these docs in the OR, they have on spacesuits. Nobody can go hang out and watch. Very strict asepsis. Definitely don't want any organisms to get into that prosthetic joint because they could lose the joint. They might have a drain. Some of them are trying to avoid that. Drains have to be managed with strict aseptic technique. You should be doing that anyway when you're managing drains or emptying drains. Wound care for the incision area. Again, now with the scopes, it's getting to be smaller and smaller incisions, but you still have one. Venous thromboembolism, that's another word for a DVT. Thrombus or clot. So post-op, these patients will have TEDs or sequential compression devices. You're watching their level of consciousness, make sure they haven't thrown something to their brain. But it's very important that they have anticoagulant therapy. They'll usually put them, post-op, they'll have heparin or Lovenox. Then they will maybe start the Coumadin or the other oral agent before they stop the heparin or Lovenox. And then they'll go home on, Brian had 4 weeks of post-op Coumadin. And he had to get his blood drawn every week, and they adjusted the dose. Okay? So you need to know about anticoagulants. What's the major risk of taking too much of these meds? Bleeding, of course. That's why they watched his, with the Coumadin, what did they test?
The clotting.
The PT, right, and then they adjusted his dose, PTINR. All right, nutrition's important. Nutrition, actually for DVT, one of the best things is hydration, keeping people well hydrated. And then if people bleed, they can get hypotensive. Or if they stand up too fast post-op. That was the only reason he got 2 nights in the hospital. They wanted to send him home the next day after his surgery. But he got a little dizzy in PT the day of surgery. He was in PT walking up the stairs the day of his surgery. The day of his surgery. He was walking up the stairs in the PT area. They had him walking as soon as he was awake enough to walk. But he got a little dizzy, so he got 2 nights in the hospital. Surgery Monday, home Wednesday morning. Vital signs, 24 hours, observe for bleeding. You're observing anywhere for bleeding, especially the dressing, the area of the surgery. But remember, they're also on anticoagulants. So stool, urine, whatever, you need to make sure they're not bleeding. Wound drainage, if they have a drain, usually less than 50 mils in 8 hours. Neurovascular compromise, what's that mean? Where's their most likely site of neurovascular compromise? In a, say, a total hip or a total knee. Which side? Which foot? The one that had surgery. Yes. Right, unless they do both knees at the same time, which I've seen. Then it's both feet. Which means you're doing the 5 Ps, right? You're checking to see, neuro, do they have nerves, sensation, feeling? Vascular, do they have what? What's vascular? Vascular is the blood supply to that affected extremity below the level of the surgery.
Paresthesia.
Okay, well that's feeling. Paresthesia is numbness and tingling. That's your nerves. Vascular. What's the most way to tell that the blood's getting there? Pulses. Pulses, color. Cap refill. Good. Very good. That's what I was, yeah, see? Cap refill. You guys got it. All right. Activity progression, which is pretty fast. They want them up.
Aren't they doing laparoscopic surgeries now with the
laparoscopes?
Yeah.
Uh-huh.
So it gets easy recovery time and
yeah. That's why they can send them home the day after the surgery. So you get 1 to 2 days after a total knee. You get like 3 days now after a total hip. and you're up the day of surgery. Unless you come back too late, then it's the next morning.
Oh, they do lipo for total hip or total knee replacement?
1 or 2 nights for a knee, 2 or maybe 3 nights for a hip. Unless there's complications. See, that's the point. That's why it's so regimented. That's why this is a really anal group of nurses. They have a protocol. You follow it. This is your pain medicine. Actually, they don't do the PCA pumps at Anne Arundel anymore. They just give them IV, a little bit of IV opiate, and if that doesn't, and if they don't need it, they'll start them right on Percocet as soon as they wake up, because they're going home the next day. There's no point having a PCA. They don't even get that anymore, because they're getting right up, self-care, do it yourself. Here's your walker. Let's go. And then you're home. Or if you're really old and you can't manage, you don't have anybody at home, then you go to rehab. And that's another big business, isn't it? Here's the abduction pillow, heels off the bed, turn, cough, and deep breathe. You still want to prevent atelectasis, post-op pneumonia, out of bed as soon as possible, pain management. And always, you were talking about confused people. Sometimes people do get confused after general anesthesia. It's really important to prevent them flying out of the bed.
And it's hard to
Injury.
reposition them as
Yeah.
rolling them. It's hard to reposition them.
Yeah, and you also want to know what was their mental status prior to their surgery. If they fall and break their hip and they have dementia, they're still going to fix their hip. Well, not always, but usually. Total hip. Here's patient teaching. Don't sit or stand for long periods. Don't cross your legs. Don't bend your hips more than 90 degrees. We talked about that. Pain management, incision care, assistive devices, a walker, usually to start, then a cane perhaps. Then the physical therapist, and they have a whole regimen they do. They start them on outpatient PT as soon as they leave. They have inpatient. Anne Arundel has something called joint camp, and at 2 o'clock every day, the volunteers come in, push them in their chairs, or put them on their walkers. Everybody goes into the big gym, and they all have joint camp. They have to have a coach, somebody from their family that coaches them, that says, you can do it, you can do it. It hurts. And they make them get up. They make them get up. So joint camp has been very effective in improving outcomes and preventing complications of immobility. And then we talked about the heparin or Lovenox initially, and then weeks of Coumadin. All right, here's your total knee. Now, the downside of some of these joint replacements is they don't always last forever. So if somebody is 60 when they get their first knee, they may get a second one when they're 75. But if they need it, they need it. So they try to wait till people are 60 to get their first knee or hip. But it depends on, how bad off it is. Post-op, what do we do ice for? It's to control swelling. It says over management of total knee. Shows you the Lovenox. Talks about the neurovascular status. You want them to flex their foot. You don't want them to get foot drop. Range of motion and prevention of complications. So again, this shows the clot that can develop, especially if you've had a total knee. Isn't that going to affect your venous return? It has to get back through there. So if you have stasis, you could get thromboembolism or a DVT. That's why they have these aggressive anticoagulation protocols. Okay, there's the immobilizer that they'll wear initially, and then less as time goes on. Elevate the leg when sitting. There are some limitations initially on weight bearing, but they'll work them up to it pretty fast. You would like them to get 90 degrees of flexion and walk independently with a walker, with a cane, and eventually without, if possible. Okay, they use the bikes in PT. They don't want you to hyperflex, which means more than 90 degrees. They don't want you to kneel because there's really nothing above it, kind of like metal against the floor. And the full rehab is about 6 weeks. People can go back to work if they have a desk job after about 6 weeks. If they're a nurse or they work for Giant Food like Brian and he's on his feet for 8 hours, it took longer than that because he had to be able to be on his feet to do his job. Okay, so rehab before going back to work. And a lot of these people are retired, but not everybody. Okay, the only thing you need to know about gout is that it's caused by an increased blood level of what? Uric acid. Hyperuricemia. So there's, people that have problems with purine metabolism and other reasons that they get hyperuricemia.
I have a question about
Don't worry about primary and secondary. There is a family history. They used to call it the king's disease. Yes, ma'am.
Is it true that people that eat too much protein, like too much meat?
Well, probably not. There is, when you read about it, it does say that there is some people that still think you should eat a low purine diet, the diet management. Most of the scientists don't really believe that that makes much difference or that it causes it. But back in the day, when they called it the king's disease, these were men. They were big, because in some cultures where there was not much food, being big was actually considered a good thing, even though we know probably shortened their lifespan, but it was considered cool. And they ate a lot of protein and other meats because they were the people that had access to a lot of meat. So, and they would have, one of the characteristics of gout is a big, swollen, painful red toe, great toe, the big toe. And it would show the king, the big fat king with his foot up on a pillow, and it was all red and swollen, eating, I don't know, shrimp and liver or something. Anyway, so that picture kind of perpetuates, but that's not really that much a part of gout. It helps you if you think about them having high blood uric acid. There is such a thing as a low purine diet, which is to avoid shellfish and organ meats, and other high protein sources, but most of the time they don't think that really helps. They do want you to increase fluid intake to circulate those purine crystals that can build up. It can build up in the kidneys. Remember, you studied uric acid kidney stones. It can build up in the joints. That's the gouty arthritis. And mostly they treat it with medications. They do tell them to avoid alcohol. It's another thing the kings did, lots of alcohol. And you should avoid diuretics. Because you don't want to get dehydrated. And aspirin actually is an acid, salicylic acid, and that's contraindicated.
Ms. Egg, I'm sorry. You said that we don't really have to go into too much detail.
No, that's all you need to know. Everything, I just actually said everything you need to know.
Okay.
So don't worry about primary or secondary. It does say that it's higher incidence in middle-aged and older men. It does have some family history. They can have, it's caused by hyperuricemia, which is uric acid elevation, right? They have inflammation, so they could have an elevated sed rate. And some of them can have chronic gout that has the little urate stones, not just in the joints, but also possibly in the kidneys. Okay, that's basically what that says. There are some drugs that can cause increased uric acid. I used to know. Diuretics, certain chemotherapy drugs can cause high blood uric acid levels. When we have patients with multiple myeloma, with leukemias, and certain other carcinomas, when we start them on chemo and we give them a lot of cytotoxic drugs and the cancer cells lyse, it lyses the cells, it pours out the contents of the cells. If they have a lot of cancer cells that break down at once, we call that tumor lysis syndrome. And with that, people get hyperuricemia. So one of the drugs they give to people getting chemo to prevent hyperuricemia is what? What's the drug we give for, not colchicine, that's specific to gout. But what's the drug we give chemo patients? I guess we haven't really done much of that. Anybody seen that in LD5 where they're getting chemo? One of their drugs in their EMR is likely to be allopurinol. Because allopurinol is the medication we give for what? Hyperuricemia, including gout. Hyperuricemia, high blood uric acid levels. So there are cancer patients, especially if they're getting chemo, especially if they have leukemias and myelomas and they're going to get multiple chemos, we put them on allopurinol to prevent tumor lysis syndrome, which is high uric acid. If you ever see an NCLEX question on tumor lysis syndrome, think high blood uric acid levels, think allopurinol. They also can get high potassium and other intracellular things too.
So is that the only med we need to know for
That's the only med you need to know.
Okay.
Allopurinol. You want to treat the underlying cause. Obviously, if it's cancer, you're treating the cancer. Doesn't really matter whether it's acute or chronic, because either way, there's a nice picture of acute gout with erythema of the great joint. And it shows you the redness and swelling. And of course, it's painful from the swelling. People can get urate crystals in other places, including at bottom kidneys. So they're going to have pain, impaired mobility, body image disturbance, altered nutrition, non-compliance. Well, that's kind of a judgmental nursing diagnosis. I don't like that word, but you will have people that don't do what?
Don't take their meds.
They don't manage the therapeutic regimen that's been prescribed. And there's a number of good reasons for that. But not taking meds is one thing for non-compliance. Not following their diet, not doing their exercises, right? We've all been a little non-compliant. Nurses and doctors are the worst, by the way. We don't believe anything our doctor tells us to do. We just do our own thing. It's not good, but that's what we do. Ask anybody who's been a nurse for 40 years like me. It's really bad. Okay. So, diagnostic studies, you can measure the uric acid in the blood. And if it's above 8 milligrams per 100 mLs, then that's high. The SED rate would be elevated. If it's in their kidneys and causes kidney damage, now you could have increased BUN and creatinine. You can do a 24-hour urine. You can do that for creatinine clearance, and also you can look at uric acid. And they could take the synovial fluid and look at it to detect urate crystals. If my toe's big and red and swollen, I don't really want somebody hitting it with a needle, but they could do that, right? All right. So the drug for gout that you see still used is colchicine. There's a new one called Uloric, which one of our faculty is supposed to be taking because she has gouty arthritis. Anyway, colchicine and Uloric interrupt urate crystal deposition. Obviously, you can still use anti-inflammatories like NSAIDs or perhaps even steroids if the NSAIDs aren't good. The steroids are really, we try to reserve that for most more severe conditions. Here's allopurinol. It can be taken over long term, increases uric acid excretion, and decreases blood levels of uric acid. Probenecin's been around a long time, don't see it much anymore. Diet, controversial, the low purine diet of organ meats and shellfish, and avoid alcohol, and try to stay hydrated. All right. So those are not autoimmune diseases, okay? OA is DJD. It has some familial tendencies. A lot of times it's from too much weight on the joints over many years. Gout is from increased uric acid. RA, rheumatoid arthritis, systemic inflammatory disease. Autoantibodies attach the connective tissue. People can have abnormal immunoglobulins. We talked about serum protein electrophoresis. They have these phagocytes that are chewing up their connective tissue, these inflammatory cytokines. These B and T cells, which we talk about as part of the immune system. Autoimmune is hyperimmune. Here's a picture of a hand of a person with late stage RA with joint deformities.
So which one did you say was autoimmune?
Rheumatoid.
Rheumatoid and
not osteo.
Okay.
Osteoarthritis and gout are not autoimmune diseases.
Okay.
And they're in the front of your chapter. Then it goes into the autoimmune connective tissue diseases. So rheumatoid arthritis, lupus, polymyalgia rheumatica, Sjogren's syndrome, scleroderma, those are all autoimmune.
Okay.
Higher incidence in women, younger women, but anybody can get them. Okay, don't have to memorize any of these words, but doesn't this look like a non-functioning hand?
Yeah.
Yeah.
I had a patient last semester in med-surg who was seriously, like, her rheumatoid arthritis was really bad, and I couldn't get a good O2 sat reading on her fingers.
Right.
I tried everywhere, and I mean, it kept saying that she
Even
was
her
satting
earlobe and
I kept saying that it kept satting in like the low 80s, and like
she
the
was
nurse
so
didn't care.
crumpled up that you couldn't get the blood supply
Yeah.
adequately to the periphery. If you can't get blood supply to the periphery, you're not going to get an accurate reading. I learned something interesting. It's in your book, but I never knew it before. Did you know that really dark-skinned people will test lower on a pulse oximeter?
Yeah, nail polish too.
Nail polish for sure, but really dark skin will show lower on a pulse ox because, well, it's just the way the light beam gets through to give you the reading. Interesting. Okay, so RA, people can have synovial inflammation of the joint. You don't need to know, the specifics, but you know they're going to have inflammation of the synovial membrane around the joint. They're going to have cartilage damage. These are some things that can chew up or break down cartilage and joints. This is a normal knee joint. Here's the pathophysiology of RA. They have something called pannus that forms. They get fibrous or scar. They have calcifications. They can also get some osteoporosis along with the rheumatoid arthritis. Osteoporosis, you know, is decreased bone density, higher incidence in people with, certain risk factors like me, old, white, small bones, family history, but also people that have diseases like RA would be at increased risk. We don't know what causes rheumatoid arthritis and other autoimmune diseases. Female, young to middle age, might be a viral trigger, incidence of RA. Now, they're selling all these expensive biologic drugs, but they're only for people that have rheumatoid arthritis, which is less common, and moderate to severe disease. So it's really not a lot of people that are going to run out and buy Enbrel, Humira, or Remicade. But for the people who do need it, it's been a real breakthrough, because it has really decreased the joint destruction. So it doesn't matter whether it's early or late. Here's some symptoms or manifestations of rheumatoid arthritis. Again, because it's a systemic disease, and people can die of it, the low-grade fever, fatigue, weakness, anorexia, the things you think about the joints, inflammation, deformities, paresthesias, stiffness. They have fatigue. They can get anemic. They can get, now when is the pain worse? The pain is worse in the morning for people with arthritis. They're stiffer in the morning. So that's why it's good to take a hot shower. They can take a hot shower, loosen up their joints, get moving, and then, go about getting dressed and leaving the house. Later, people can get inflammation of the nerves, the vessels, the area around the heart, the fibrous membranes around the lungs. They can get nephritises. All of this also happens with lupus. These serous membranes become inflamed. Sjogren syndrome, which is the really dry mouth, dry eyes. That's Sjogren syndrome, okay? You can get that. Diagnostic studies, ANA, anti-nuclear antibody titer, commonly elevated in rheumatoid arthritis and lupus. ESR elevations, SED rate of inflammation. And there is something called rheumatoid factor that they can test in a rheumatology panel. RF or rheumatoid factor, which may or may not be elevated. They're going to do a CBC. They're going to look at their renal status with creatinine, look and see if their platelets, in addition to their red cells, may be low. Because if your platelets are low, you are at risk for bleeding. X-rays, CT scans. Arthrocentesis means what? In a centesis, you're going to do what? Pull fluid out of the joint. Right. Bone scans. The nuclear medicine scan can scan all the bones, see if there's abnormalities. They can do MRIs. And I mentioned serum complement, the C4, C3, serum complement decreases in autoimmunity. It's used up. Another test in the rheumatology panel. Here's a normal hand. Here's a rheumatoid arthritis hand with bone erosion. Yeah, these pictures are available to you when you study in Blackboard. Here's some nursing diagnoses. Obviously, problems with pain, mobility, fatigue, body image, and all kinds of other things, depending on the severity of the disease. You're going to assess their eyes, their vision. Xerostomia, fancy medical word for dry mouth. We'll talk about that with oncology, too, when we do radiation of the head and neck. Skin bruising can be from the lupus, from the vasculitis. You can get a rash with RA or lupus, and also the meds. What's the medication we give for RA and lupus that can cause easy bruisability? Prednisone. Trick question. Prednisone makes their skin real thin and bruisable. Okay, they can have redness, inflammation, sometimes alopecia. I think you mentioned that with RA and lupus. I don't know what alopecia is. Buccal lesions, which are usually painless. Pleuritis, the pleural cavity, hurts when they breathe. Changes in pulses, changes in bowel habits, some anorexia, nausea, vomiting, which can decrease their weight. Or if they're taking prednisone, they might increase their weight. Okay, ADLs, headaches, tenderness, range of motion, and muscle strength. Okay, so you can read this. Takes a village, right? PT, OT, maybe some counseling. Good pain management with a person that's a pain management person. They have doctors and practices now just for pain management, and they have a whole bunch of things they can do. Energy management, we talked about energy conservation, the psychosocial, the body image, all those kinds of things, and the pharmacology. Now I don't know if this page number is right. You might, it's in chapter 20, but there's a list where they have the pain meds, antipyretics for fever, anti-inflammatories, NSAIDs, and steroids. Immunosuppressive drugs can be used sometimes. They don't use as much of the old immunosuppressives, the drugs we give for organ transplants, the drugs we give that are like chemo drugs, because now they have the biologics. It's recombinant DNA technology. It's very expensive. These biologics work in a new way, and they actually are anti-inflammatories in a new way. They are what we call anti-tumor necrosis factors, which turned out not to be just for tumors, but that's who developed it. And it changes the immune function and decreases the disease. It actually slows the disease progression. Are they a magic cure? No. Have they made a huge difference in RA and lupus? Yes. And then there's some old, what we call disease-modifying anti-rheumatic drugs. Now here's a concept. Hint, hint. When they take these disease-modifying anti-rheumatic drugs, some of these drugs, they don't work right away. They may take several weeks or even several months to really tell if they're going to be effective in this disease. So initially, there is one drug that works fast that they can give them, and it's what they call a bridging medication. They're going to give it, it's going to work right away, works right away in your lungs, works right away in your joints. And then if that's a bridging medication that they can wean them off of as they see whether these disease-modifying drugs and biologics are going to work. So what's that drug? I tried to give you some hints. I said inflammation works fast, even in your lungs. Steroids. And I said wean. Prednisone. Yeah, steroids, exactly. Corticosteroids. That's the bridging drug that works quickly. My mother had terrible joint pain. She couldn't even lift her arms up. She went to her doctor, actually went to a rheumatologist. He said, here, take this. If you feel better in the morning, we know you have polymyalgia rheumatica. If it doesn't help you, you don't have it. She went home, took prednisone, her pain went away, she could lift her arms. He said, you have PMR. Polymyalgia rheumatica is an autoimmune connective tissue disease, more common in old ladies. So she took low-dose steroids for a while, and she was fine. Anyway, it works fast. That's why we give it in the ER for people who have what? Asthma, because it will turn it around quickly. Here's just some pictures. You can look at this. The aspirin-type drugs can cause GI intolerance, GI bleeding. Purpura is the little broken blood vessels if they have too much anticoagulation. Aspirin's a pretty powerful drug, aspirin and NSAIDs. Here's some examples of NSAIDs, ibuprofen, naproxen, Celebrex, etc. Why do we give it with an H2 blocker? Agamed, Pepsid, Zantac, Axid, or a PPI, proton pump inhibitor, Prilosec, Prevacid, Nexium, Protonix. Because it causes gastritis, and all those drugs I just mentioned, decrease stomach acid secretion. Good. Okay, and then the disease-modifying anti-rheumatic drugs. Plaquenil. Plaquenil is great stuff, especially for lupus patients. I heard a rheumatologist say it should be in the water supply of all people with lupus. It does decrease the autoimmunity. It can cause eye problems. They should have an ophthalmology exam every 6 months. Some of these older drugs like sulfasalazine and minocycline, don't see them much anymore because of the biologics. Rheumotrex we talked about. It's a slow-acting immunosuppressant. Now we have Enbrel, Remicade, Humira, Orencia, Kineret. This is the new kid on the block. Often has to be done in an infusion center. They're expensive, but they're wonderful. They're contraindicated for somebody to start on this if they come in with what? It says it in the commercial. Don't start these drugs if you have an infection, because they are immunosuppressants. And here's glucocorticoids. She's got a little bit of a moon face, a little thick neck. It's fast acting, which I mentioned. It's anti-inflammatory and it's immunosuppressive. Pulse therapy means you give it like every other day. You give it in the lowest possible dose and as infrequently as possible to try to prevent adrenal suppression. Sometimes we still use gold, not much anymore. Actually, gold, very expensive. Gold's expensive. You can give it IM or orally. It can cause rash. The thing we need to know about gold therapy is it causes rash. Again, used for rheumatoid arthritis. And then here's just another chart. You probably don't have it in your outline view, but it's on your other PowerPoint. And it just talks about cool ways that people can help to manage their disease. Some people like magnets. Some people like hot showers. Everybody probably likes that. These are just examples of managing pain and immobility, etc. Okay, lupus. Don't worry about the discoid type. Those are people fortunate enough it only affects their skin. Most people have chronic systemic lupus. There's mild, moderate, severe. There's variants of systemic lupus. My daughter has, fortunately, a variant of mild systemic lupus, but she hasn't had the kidney and organ damage. That's higher incidence in the African American women. But anyway, she does have lupus. Okay, so she has increased ANA, anti-nuclear antibodies. She does have some increased double-stranded DNA. So it shows the immune complexes and the hyperimmunity, the autoimmunity. They can have vasculitis, which is blood vessels, or renal damage. So if somebody gets lupus nephritis, that's a big deal. They can go into renal failure. Can be fatal. 90% live beyond 10 years, and that's getting better every day. Especially now that there are some new drugs. For over 50 years, the only drug for lupus was prednisone. Depending on where this inflammation is, it can be neurologic, CNS. It can be pulmonary. Serous membranes that line the lungs. It can be cardiovascular, the heart, the blood flow to the heart. It can be GI. It can be renal. Lupus nephritis is the leading cause of death from lupus. People can end up on dialysis. Musculoskeletal, they have arthritis. They also have joint pain. Pretty common with all of these autoimmune connective tissue diseases. Here's a butterfly rash. They could have some fever, like with RA, if it's exacerbated, fatigue. The photosensitivity you mentioned, they should stay out of direct sunlight. It's not the heat, it's the light itself. So they should stay out of the bright sun. They should wear hats, long or scarves, etc. Here's a discoid lesion on the cheek. Here's the systemic things. Shows the brain, the skin, the heart, the lungs, the kidneys, the joints. Here's some rheumatology panel things they'll look at, in addition to the CDC. Treatment is usually prednisone, some kind of cortisone, corticosteroid, Plaquenil, maybe some immunosuppressants. Now we do have a brand new, I think it's called Benlysta. I tell you, I only remember the brand name. It's some kind of biologic, some kind of monoclonal antibody. And you want to have aggressive treatment. These people should be with rheumatologists, other specialists if necessary. The rheumatologist will manage the course of this chronic condition. All right, the last thing I kind of want to mention is fibromyalgia syndrome, because it is at the back of your book. The good news about fibromyalgia is it is not an autoimmune or inflammatory disease. It is not progressive. Okay, so it doesn't cause organ or joint damage. What it causes is chronic pain and fatigue. When it was first identified, which was pretty recently, used to call it crazy lady syndrome. I'm not making this up. Middle-aged women who don't sleep and have pain, they thought it was all in our head. I've had it since 1989, so they really didn't know what it was then. The people that identified it that were from infectious disease called it chronic fatigue syndrome. The people that identified this pattern of symptoms in rheumatology called it fibromyalgia syndrome. So it's some kind of chronic fatigue, fibromyalgia type of immune dysfunction syndrome. So they can't even figure out what the name is. But if you push on these places on my body, here and here, here and here, you know, that kind of stuff, here and here, I have a reproducible tenderness, a chronic pain condition. Muscle tenderness, they think it's probably from the brain dysfunction in the thalamus and hypothalamus. We have chronic muscle pain, myalgia. People can have all kinds of other symptoms throughout their body. Neuro, brain fog, fibro fog, a little bit of chest pain, abdominal pain, some problems with GI and GU. Had a friend with fibro who had a hysterectomy. Nothing wrong with her uterus. So here's the deal. The most important thing that I have found, living with this for many years, is it's a sleep disturbance. So those of you who work nights and don't get good stage 4 sleep are probably feeling the symptoms of fibromyalgia. Chronic fatigue, muscle pain, problems concentrating. Okay, you see where I'm going with this. It seems to be a sleep disorder. So it's higher incidence in women with kids, women who sleep with that one eye open all night long looking at the clock. Yeah. Right? Well, you're not getting stage 4 sleep. So the best treatment for this, one of the things they need you to do is move, exercise, eat well, all of that. But the main thing they do is sleep management. So I actually take a little bit of trazodone, Deserel, at night to try to increase stage 4 sleep. If I don't take it, I can tell. I've been on it for 20 years. Little low dose, pretty safe drug. I've tried amitriptyline and nortriptyline. Those are the old tricyclic antibiotics, antidepressants, but they make your mouth dry and you wake up groggy. So you have to be careful with the antidepressants. But the trazodone, Deserel, seems to work for me. It's old, it's cheap, and it seems to help better sleep. They can use Zoloft or Lexapro, which is SSRI. You can use NSAIDs, ibuprofen, physical therapy, regular exercise, and like I said, massage, yoga, all that stuff saved my life. A nice warm pool when I was really bad, because I was out of work for a year or two initially.
Isn't Cymbalta
Cymbalta is an SSRI. It's one of the many SSRIs, the selective serotonin reuptake inhibitors that they give for people with fibro, and it helps some people. Yep. And these are just examples of other connective tissue diseases. So when you hear of these, don't go, oh my God, we didn't study that. Look at the question, if it's say NCLEX, and look at the commonalities in what the nursing management would be for working with anyone that has, say, an autoimmune connective tissue disease, which is systemic, or the ones we talked about, like osteoarthritis and gout, which still cause joint pain and immobility, right? Okay, and there's the summary of what we covered. Questions? All right, good luck on your PEDS test. I said nutrition and hydration, you should probably try that. You don't want to get hypoglycemic in your test, right? That's never happened to me. You need food for your brain. You probably also need to walk outside, stretch, take a deep breath. Those of you who didn't miss this class to study for PEDS will probably be happy next week. Actually, I got a couple emails from people that said they had family emergencies, so that's fine. All right, thank you. After the tests get really noisy, though. Everybody's in the hall yelling. This is still pre-test, so you're very quiet. Good luck. Thank you. Some of you are going to see in lab, so you're going to be moving around there too.
Yeah.
Come to lab, we're going to do a sim lab. Don't panic, it's fun. Tell yourself that.
Alrighty.
Do you want to see the two pictures? that I
Oh,
sent?
if you took pictures, I'll look at it.
It's just, so this is the second part of, I got a 98% total in this one.
Well, it probably helped you to do it.
It did, but, so I was just upset that I couldn't save my
It wouldn't let you
results.
print it. So you could the first time, but now you can't.
It wouldn't save, and this was, I think, the last, part of it, I got an 86 on it, part of the,
Okay.
and that was
Okay.
315. I just wanted you to see the date, and I did it, I started Sunday night because I tried last semester to redo it, great. Miss Handy told me that I could redo it, and I even called Kaplan last semester, and they told me that they hit new record. So you can click on retake, and it'll come up asking you if you want to continue with the previous record or do a new record. And I've always hit new record, and my assumption was that because of the state time system. But it doesn't say time system.
Once you go back and do it again, it doesn't say.
Right. So that was yeah. So I was just frustrated because I did a lot better. So I just wanted to let you know that.
Poor Desmond still needs to get in and do it all.
Yeah.
But yeah, the fact that you could do it the second time and improve, that's good. That's helpful.
Okay, I just wanted to make sure I showed you something. But you can see what we do on capital.
Yes, we can. Yes, we can.
Okay,
We
so.
can go in through administrative and look.
Okay, so I figured that
So
as
if-
last resort, you would be able to see that.
If somebody has done it, I can tell they've done it.
Okay,
And hopefully Kaplan's working so that if I don't see it, they haven't done it.
okay.
That I'm not sure about. We
Thank
still need to
you.
get, I'm gonna talk to Michelle, Desmond.
Okay.
The last time I talked to, there's 3 of you, the other one is Julie, and somebody else that weren't in this program last semester, so you're not in the system. It's a system thing. But I thought she sent your name and they said they had done it. But I'll check with her. She's the administrator. Are you gonna help give the PEAS test at all?
No.
Gonna come to SimLab? Some of you have it at 12, some of you have it at 2:30, right?
Yeah.
You have it at 12, okay.
Normal store.
I know, and we didn't do
That's the
anything.
normal storage. Storage, and after that, you go back and for a premium.
Not carry the second
Then you
back.
start.
I don't know.
Guess when I was like, I had my door asked
I know, so we have to split it.
Oh. And the cream. And the cream.
Okay, I'll do this one.
Oh, I mean,
Yeah.
how about the other one?
I'll ask Nima if she can do that. It is.
no, that hinders the.
I mean, I can do either one. I'll ask her if she can.
Okay.
I hope this is
Oh, that's all below.
Because she can observe. She observes that when we have these exams, the attendance is like, when she mentioned that the other class, Armstrong class, like 11 people are absent. Yeah, she mentioned that.
Oh yeah, okay. I think she said. I think she said that that they have 11 people.
No, the 11 people absent. Good luck. Mama, why is it so cold out here?
It's cold. I need to put on my jacket. And I want to use the restroom.